Hello, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor of JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, send us your questions or comments on Twitter and just mention us at JAMA Network Open, or you can just put something in the comments on Facebook or YouTube. Also, join us for a special episode next week. We're going to do an end-of-the-year review. In addition to some of our normal stuff.
So exciting.
Great. Speaking of exciting, we've got our first paper today is the association of patient and visit characteristics with rate and timing of urologic procedures for patients discharged from the emergency department with renal colic. And we've got first author, Dr. Elizabeth Schoenfeld with us. Welcome.
Thanks for having me.
Great. So tell us a little bit about yourself and why you did the paper.
So I'm a researcher and emergency medicine physician at Bay State Medical Center, which is now known as the University of Massachusetts Medical School Bay State campus, and we're out in Western Mass. And this research emerged out of some really patient-centered research where we were looking at what did people need to know to decide whether they, as a sort of an individual, really needed a CT scan at the time of an ED visit for suspected kidney stones. And one of the questions that came up that patients wanted to know was, well, what's the chance that I'm going to need a procedure? And we know that sort of traditionally we've answered that question based on the size and location of the stone. But the reality was that the majority of stones are small and the majority of them are going to pass. And so answering that question via CT scan doesn't always make that much sense. And so we wanted to see if we could answer that question for a sort of a general population, although it wouldn't necessarily be a sort of personalized answer. If we could get a better sense of that on a population level, that might help us answer that question for both patients and clinicians. If you think about why people do CT scans, planning for a procedure is sort of one of the number one reasons that physicians say we should get a CT scan in the case of suspected renal colic.
Great. All right. And what did you do here in the study?
So we looked at the Massachusetts All Payers Claims Database. So this is a really cool database. It's a little bit hard to use, but it's basically all claims, all ED visits for basically every person in Massachusetts unless they are uninsured or have Medicare, so the older population. So that means we really captured everyone from 18 to 65 or 64. Because Massachusetts' uninsured rate is only 3%. You really capture private insurance and Medicaid really well. And we weren't so concerned about capturing the Medicare population because we wanted to look at younger patients. And so we were able to capture 4 years of data for patients, essentially everyone in Massachusetts, anyone who was seen in the emergency room with a diagnosis of a kidney stone, and see what happened to them in the subsequent 2 months. And this was, in my opinion, an improvement over some of the other studies that I've done and other people have done because we didn't have what happens next to a lot of these patients. We knew whether they got admitted, whether they got a procedure, but we didn't know if they got a procedure 3 weeks later. So that was sort of the question we wanted to answer. When are they having these procedures and how many of them are actually having procedures?
Yeah, and you had pretty good numbers. So over the 4 years, you had 66,000 visits by 55,000 patients, 60,000 of which were discharged from the ED.
Kidney stones are very common, right? So
Yep.
about 1% of our patients have kidney stones, and it's one of the top 10 most common discharge diagnoses from the emergency room.
Interesting. Yeah, and then I was, I'm not sure what to make of it. So it was 77% of patients got CTs in the ED?
Yep.
Yeah.
And you have to remember that many of these patients have a history of stone. So
Right.
you could say that if it's a first-time stone, that CT was indicated. But if it was a second-time stone, we're really supposed to be avoiding CT. And we know that a number of those patients have a history of stones.
Yeah, there was the big RCT, was it 2014, where they randomized people to CT, radiology ultrasound or point-of-care ultrasound in the ED, and basically everybody did the same, regardless
Right.
of how it was done. So I know for me, in general, if it's younger patients, especially if it's a history of stone and it seems typical of their stone, try to not do a scan with CT, because really all we're looking for is either complication of the stone, so big infection, big obstruction, stone that's not going to pass, or a differential. So if it's a 65-year-old who hasn't had a stone before, the chance that it's like cancer or AAA is much higher than, if you've had 3 stones and you're 27.
Exactly. And I think a lot of people are moving towards that. There's a lot of good evidence out there. And this is just another piece of the puzzle to help us get more comfortable with that idea of, okay, we don't need to do that stone right now. And I think one of the things that we saw in the study is that your rate of needing a procedure within a week was 1/15 the rate of getting a CT scan. And so it's a lot of CT scans for the number of procedures that happen in the next 7 days. So why don't we wait until we really know clinically that you need the procedure and then get the CT scan?
I wanted to follow up on that because at one point in the discussion, there's mention of the fact that ultrasound is the primary diagnostic modality of choice. Is that right, or the recommended one? And I wanted to just get from both of you, actually, just working in the ED, your sort of sense of why that may not be utilized to the extent that it could be, given the recommendations.
Yeah, so one of the problems is that there's a couple of different recommendations. And then the other problem is that once people get the ultrasound, they don't always know exactly what to do with it. So I've had people who get the ultrasound and there's a little bit of hydro and they say, oh, there's hydronephrosis. I think that means I need to get a CT scan. And then there's other people who say, oh, there's no hydronephrosis. Now I'm not sure it's a stone. I think I need to get a CT scan. So people will use the ultrasound to justify the CT scan because people feel really comfortable getting CT scans. On the flip side, I've had a lot of very smart people say, well, the ultrasound itself doesn't actually change anything. If they have hydronephrosis, but they're feeling better, I'm going to send them home and we're going to do conservative management. And if they don't have hydronephrosis and they're not feeling better, we go by how they're feeling. It's really very clinically based, the management. And therefore, what I use the ultrasound for is to make sure that they have 2 kidneys, because if they only have 1, that changes things. And to just make sure they don't have severe hydronephrosis, which we know is really like less than 1% of patients. So for the most part, the ultrasound itself is not always necessary either.
Right. Well, first I want to welcome Fernando May Diaz and Chris Brooks, who are watching. So welcome. We're talking about ED visits with renal colic and what happens to those patients and how many get procedures. My practice is interesting. So we don't bill for our point-of-care ultrasounds in our ED for complex reasons. And it's great for me because especially working in a teaching environment where, when I have a pretty straightforward patient with a senior resident and they say, this is their kidney stone pain, they've had it before, blah, blah, blah. There's not a lot I really need to do clinically, and a lot of it's just kind of the being a doctor and laying hands on the patient, and ultrasound kind of makes me do that. So I bring in the machine and I, by definition, am spending time with the patient and laying hands on and go, yeah. I remember just having, I think it was right around the time that other paper came out, having a good conversation with one of the smartest people I know in EM who's saying, well, what do you do? Is the ultrasound positive if you find something for a stone or negative if you find for something with a stone? And for me, it's kind of answering mostly the wrong question because like you said, most patients don't have severe hydro. And if they do, they're generally kind of sick. And really, I'm mostly looking for other things, and the ultrasound's not really showing me those other things.
Yeah. I have to say I use it for talking to the patient. I think it helps you talk to the patient. If you see a little bit of hydro, you say, you know what, this really confirms what we were thinking clinically, that you have a stone. I'm not seeing massive hydro, so that's good that I'm just seeing mild hydro. You'll probably pass it. And if I don't see hydro, but I still think it's a stone, I say, I'm not seeing any swelling, which probably means that this is a smaller stone. And that's good news. And I want you to do all the same things anyway. I want you to watch for fever, I want you to hydrate, I want you to take these meds. So, but I do think it gets you by the patient side and encourages that conversation.
Right. And that's one of my favorite parts where you're talking about with the discharge instructions is this isn't complicated stuff to send patients home with. And the things that patients need to come back for are things like pain, fever, trouble urinating, et cetera, which are things that, people notice. It's not like, oh, if you have tingling in your 3rd and 4th finger, then you're having a major problem. And second, just pain by itself is a good reason to come back if your pain's too bad to manage at home. And that kind of covers most of the complications that happen. But back to your paper. So it looks like 5% of patients got a urologic procedure a week after being discharged from the ED?
Yep, that's what we found of the people initially discharged. So there were about 9% who were initially admitted. And we know those patients. Those are the ones who you can't get them feeling better in the ED or they come in with a fever. So we did not exclude people who had signs of infection. So that whole group, sort of signs of infection or not getting better, did initially get admitted. But it was only 9%. So we're really talking about those people who are looking good. You treat them and they sort of feel better.
Yep.
The other thing I thought was sort of interesting is that it looked like the Medicaid-only insured participants or patients actually were associated with a lower rate of subsequent urologic procedures, but higher rates of primary care visits. I wondered if you had any thoughts about that. I know you go into it in the discussion, but I thought it was really interesting.
So we suspected, that this was one of our hypotheses, is that we thought that this would happen. And the reason for that is that in our own experience, many urology groups and many physicians in general will get you in faster if you have better insurance. And this is a disease process where getting you in faster changes the outcome. So I have had the experience where a patient will have a very small stone. But a good example, I had a young woman who we were discussing whether she needed a CT and she said, well, I'm going to go on a cruise in 5 days. And it's like, you know what? If you're going to go on a fruit cruise in 5 days and you have a small stone, the urologist would be happy to help you with that. On the flip side, if the urologist has only slated a certain number of appointments for Medicaid patients and they can't get you in for 2 weeks, you're more likely to pass that stone. So the difference between the insured patients and the Medicaid patients or the commercially insured patients outcomes, it's not really clear if that's overuse of procedures for the insured patients or it's underuse of procedures for the Medicaid patients. It's really, you can't really tell from this data. It's probably a little bit of both. I think the fact that the Medicaid patients had more primary care visits was like almost a little heartwarming, because it was like,
exactly.
Like, oh, good. People have access and they're going to their doctors, which I think is a nice thing about working in Massachusetts.
Right.
Yes.
And similarly, I imagine there's probably 2 reasons why people who see urologists are more likely to get procedures. One is it's probably the people who are more likely to need a procedure who are more likely to see a urologist, and that's a step towards getting the procedure. And second, just the more you see more contact you have with a proceduralist, there's kind of not necessarily nefarious, but cynical reasons why the more contact you have with somebody who does procedures, the more likely you're going to get a procedure.
If you have an expectation that last time you had a kidney stone, you went and got a procedure, and you still have the urologist's phone number and they consider you one of their patients, it is very easy to go get a procedure. And I know some Canadian cities have battled with this a little bit because they had very high procedure rates that didn't seem to make that much sense. And they then talked, and then patients would come in and say, I'm here for my procedure. You know, that's what we do. I come in, I get my procedure, my CT and my procedure.
Yeah. All right. Well, this is really great research. Thanks for publishing it in JAMA Network Open, and thanks for your time today.
No problem. Thanks for having me. Happy to talk about my research, your research, everyone's research.
Research is good. All right. Take care.
Bye. Take care.
All right. We've got Mito who's joined us. Welcome. We are moving on to our table of contents. And the first one we have is an interesting EHR paper, which is a rare combination of words, where they, authors at Beth Israel Deaconess in Boston, one of the Harvard hospitals, incidentally where the House of God allegedly took place, they changed their EHR to flag orders that had already happened to reduce duplicate orders. Figure 1 shows what they did. It's this nice little passive thing where basically there's a little red box around the check boxes for orders that already happened. So, you know, like I know in my place we have nurses will order CBCs and chemistries from triage a lot of the time, and sometimes hard to tell initially, but in this system it kind of flags the orders. And some of the more common EHR systems like this, they let you put in the order and then there's like a hard stop or something interrupts you or actively happens or like kind of yells at you after the fact that's a duplicate order, whereas this one's kind of passive in the process of ordering it. So they did it over 3 years from 2012 to 2015, first on labs, then on medicine, then on radiology imaging. They had 185,000 patients overall, about 110,000 of each orders. And not surprisingly, there was a decrease in labs from 4.5 thousand to 2.7 thousand. Radiology went down from almost 1,000 to a little under 800, with IRRs of 0.5 and 0.6. Interestingly, there wasn't really a decrease in duplicate medication orders, which is interesting. And the way they define it was if an order happened on the visit and then the second one was ordered and then canceled was how they ordered or how they named a duplicate. I found it really interesting that there wasn't a difference in the medication ones. I guess maybe we're more thoughtful about medication orders.
I agree. I would have thought actually that would have been the place where that you would have seen that change. But I do have to say I felt kind of nice. I mean, it was nice reading this because I think, you know, when we think about sort of decision support tools, there's always this concern that people have a little bit of fatigue associated with the EHRs and yet another tool reminding you to do something else. And maybe part of the trick here was the fact that they were sort of passive visual cues or described as passive visual cues, which made it less sort of burdensome or cumbersome. But it clearly, you know, was effective at least in certain areas. But I'm not sure about the medications.
Yeah, that's interesting. Yeah, and one of the things they talk about is they estimate that it takes a minimum of 9 clicks plus a password entry to cancel an order.
Right.
Which is a lot. And everyone always talks about the clicks. And one thing that's always nagged at me is it's not just the click, there's like that little bit of a lag every time you click something too while the computer's working, which is like way slower than almost every other system. I'm an optimist, as you know. The thing that's nice here is we know there's a lot of unrealized potential in electronic health records, and this is kind of one of the nice ways that people are moving things forward.
And I can't recall this because this was in a single center, so they were using a specific type of EHR, right? So, but you know. so it may only be applicable in this particular setting, but it's still sort of a step in the right direction, I guess, or in a direction.
Right. Yeah, it's definitely in a good direction. Like I know for me to find a duplicate order, basically I have to at least like queue the order up. Like I have to start the order, and before I sign it, it usually shows. But even that's not perfect, and sometimes it still doesn't even flag it at that point. So it's tricky. But again, moving better. They calculated that they would save 18,000 clicks, which translates to 16 and a half hours of regained productivity, which is a lot. But that's also over 3 years. That's only like 2 shifts. All right. I'm going to welcome Tala Elia, who's joined us. And what do we have next?
Okay, so this is the Association of Beta Blocker Use with Heart Failure Hospitalizations and Cardiovascular Disease Mortality among patients with heart failure with a preserved ejection fraction. This is a secondary analysis of the TOPCAT trial. And the aim of this study was to try to understand the association of beta blocker use with heart failure hospitalizations, but specifically looking at preserved ejection fraction, because beta blockers, are prescribed to most patients with heart failure, even if they have preserved sort of HFpEF, as we call it, or as it is called, I guess I would say. But sort of the effect on HFpEF is actually really not that clear. And so they looked at 1,761 participants, again from the TOPCAT trial. They stratified patients based off of their ejection fraction, so 50% or greater, sort of indicating HFpEF. And you can see the results in Figure 2 and in Figure 3, but they essentially found that beta blocker use actually increased the rate of hospitalizations in patients with HFpEF, specifically with an EF of 50% or greater, with no change on cardiovascular mortality. And for patients with an ejection fraction between 45% and 49%, there was actually no association or no such association. So kind of interesting stuff. I really liked the figures. Yep. I always like the figures. But I wanted you to talk about it because I know you like the spline.
Yeah. Figure 3 is great. Not only are splines great figures, but it's fun to say spline.
Yeah, exactly.
And basically what this is showing here is that as the EF increases, there's the hazard ratio changes for hospitalization. So it's interesting. And it's also just interesting to me because, obviously we do a ton of cardiac research in general, but I think just the kind of arc of beta blockers and evidence-based medicine is really interesting where, decades ago it was beta blockers are bad for MI, not because there's any data on it, but because, MI is a problem of, decreased cardiac output and you die of cardiogenic shock when you have a heart attack and die. So physiologically, beta blockers should be bad. And then data came out that, it turns out people live longer if you give them beta blockers.
Right.
So it was an evidence-based medicine triumph. And then a bunch of different studies started to kind of delineate which groups did better and which did worse and kind of helped take the big EBM into more not personalized medicine, but better medicine.
Closer to it, I guess.
And it's also just interesting to me just because, cardiologists love beta blockers.
Yes.
Like Germans love David Hasselhoff. So this stuff's really interesting to me, just as we get better and better. Obviously, this is observational data from a randomized trial, so this hypothesis is generating.
Yes.
So nobody is saying to stop giving beta blockers, but this is, certainly might provide some equipoise for your future trial.
Yes, absolutely.
Great. Next up, switching gears a bit, we've got a paper looking at the association of special supplemental nutrition program for women, infants, and children with preterm birth and infant mortality. So basically, WIC, the Women, Infant, and Children Program, is a federal program that provides basically food stamps, other support for pregnant women and children for a few years. It's like many federal assistance programs. You can basically get eligible if you're already eligible for things like regular food stamps or SNAP. Or Medicaid or temporary assistance for needy families. The federal limit for this is 185% of the federal poverty limit. What's amazing to me is that there's basically 43% of all women in the U.S. Who are pregnant in their study were on Medicaid. The rates of WIC started at 47% in the study, went down to 38% by the end from 2011 to 2017. And 53% of all infants in the database were had WIC support, which to me is just kind of more of just like how low incomes are in America in general.
Yeah, absolutely.
So that 185% of the poverty line limit for 2019 is for a single woman would be 22,500, and for a family of two would be 30,000 $500, which is just not a lot of money.
No,
yeah.
definitely.
And so they looked at 111,000 expectant mothers with Medicaid and live births 2011, 2017, basically just selected states that had data available based on computerized records, et cetera. Found that 71% received WIC benefits, so 71% of the women in Medicaid. It did change during the time course of the study from 80% to about 68%. I think a lot of the lowering had to do mostly with just the economy doing better from 2011, 2017.
True.
They didn't comment on it much more, but that was
Right.
still to be just overall. There's been generally good things. There might be some other stuff in there that I don't know about. And basically, they found that the odds of preterm birth were lower for women in Medicaid if they were getting WIC than if they did not, with an odds ratio of 0.87. And figure 2 kind of shows these differences graphically, and the rates of extreme, very premature birth or moderate to late premature birth are just markedly different, as well as infant mortality in the following year. And there's, from their discussion, there's a ton of data on this, and it's interesting because you would expect there might be some selection bias where higher functioning women or women with at the higher end of poverty with more money might be able to do better, but actually it's kind of the opposite, and that, I don't know, and it's not just that people who get WIC are healthier than people who don't get WIC.
Yeah, and I thought it was interesting because they actually commented on the authors commented on the fact that the evidence to date has been somewhat nuanced or not quite controversial, but at sort of opposite ends of the spectrum, and part of that they speculated was perhaps due to some of those differences. So I thought it was kind of interesting. I mean, but I think that these results actually make the most sense to me intuitively. You know, if you have supplemental nutrition, if you have good nutrition while you're pregnant, which is a very intense period of time, you know, your children will do better. Preterm birth will be lower. The incidence of preterm birth will be lower. So to me, that makes sense.
Yep. And also, they also mentioned that WIC has good education and support for breastfeeding as well, which probably helps contribute to the lower infant mortality rates for women who are able to breastfeed. So on that note, and the infant mortality rate similarly was an odds ratio of 0.84 for women on WIC and Medicaid.
Yeah.
And basically, you know, this isn't causal. This is observational data, et cetera, et cetera. But the women and children who are getting government benefits did better than those who didn't. And nutrition support, like you said, seems to be helpful for people. I'm going to welcome Jay Hincapie Castillo. Welcome. We are moving on to what's our next paper?
Association of aspirin use with mortality risk among older adult participants in the prostate, lung, colorectal, and ovarian cancer screening trial. This is a cohort study from this large trial that occurred over many years, I think from 93 to 2001. And this was specifically looking at the association of aspirin on all-cause any cancer, GI, or colorectal cancer among older adults, so adults over the age of 65 or older. So they had 146,000 participants, which is pretty amazing. And they ended up finding, investigators ended up finding that use of aspirin 3 times or more per week was associated with a decreased risk of mortality among all of these sort of categories. So all causes, any cancer, colorectal cancer, and GI cancer. And then what's sort of interesting to me is that then they stratified this by BMI, actually. And they found that for a BMI specifically between 20 to 24.9, there was still a decreased risk with the use of aspirin 3 times or more per week, but only in the all-cause and any cancer groups. Whereas for those in a BMI between 25 to 25.9, the all-cause mortality was decreased in the all-cause, any cancer, GI, and colorectal cancer groups. So again, this is sort of an observational study. Again, this is sort of the theme of the week today. But I think it is sort of interesting. And I actually didn't really know about this sort of thought behind aspirin and, you know, potentially reduced risk of mortality in cancer. So I thought this was kind of interesting from that perspective as well. Yeah,
it's interesting. I definitely heard the observational links before that have been seen. And apparently they talk about the Aspirin trial, which was an RCT, which actually showed, in contrast to all the observational data, an increased risk of death with aspirin.
Yes.
So I'm curious, and this is, you know, that kind of marks them as one of the people who's more likely to die of an MI than their cancer.
Right.
Or is it just a marker of people who have access to a doc who's therefore prescribing or telling them to have aspirin? I remember, this is, you know, not scientific, but kind of, I remember when somebody was, a cardiologist was talking about the TIMI risk factors and why the way to think about aspirin as a TIMI risk factor to have you take an aspirin in the week is if somebody decided that you need to be on aspirin, somebody's probably decided that you have risk for cardiovascular disease.
Yeah, right.
So
right.
it's interesting. So who knows? But there's a lot of patients.
Yes.
And I don't know. All right. So speaking of things I don't know, what's next?
So I really liked this paper. It was effective true and sham acupuncture on radiation-induced xerostomia among patients with head and neck cancer. And this was an RCT, which is really cool. So apparently, xerostomia, I think I'm saying that right, xerostomia.
Sounds right.
Which is dry mouth, extremely dry mouth, is common in, it's actually radiation-induced xerostomia is really common among patients with head and neck cancer that have radiation therapy.
Right.
And so there have been thoughts that maybe acupuncture could prevent this or could help with this. We're not really clear. So they did this 2-center RCT in which they looked at standard care versus getting true acupuncture or sham acupuncture to see if there was any improvement in xerostomia. And the way that they measured this was through a questionnaire. And then through the questionnaire, they sort of got a xerostomia score, and they wanted to look at the scores at 1 year out from radiation therapy. And so they enrolled 399 patients. 339 were ultimately included in the analysis. And they found that compared to standard care, true acupuncture did have a statistically significant lower xerostomia score. And then there was also a marginally lower xerostomia score in those that had the sham acupuncture, but this was not statistically significant. So I think we've been fine. I think there have been more and more studies or discussion around ways in which sort of complementary medicine can be an adjunct, and particularly for symptoms that can be really bothersome to patients. This is maybe one potential outlet to consider. And I also thought that this was sort of interesting because that they used the sham as well. And I think that it just sort of, the results sort of demonstrate the importance of having a sham when you're doing any kind of device or, sort of intervention like this.
Cardiac catheterization, for instance.
Yes.
Yeah, I found it really interesting. Also, the description of the sham procedures, they called the sham procedure involved a real needle at a real point not indicated for xerostomia, or real needles at sham points and placebo needles at sham points.
Yeah.
Which is interesting. I think this adds to the bigger body of knowledge or body of data on acupuncture, which I don't know a lot about, but I'm pretty sure is a big Rorschach test of the difference in studies. A lot of different people will criticize them or find them supported based on a lot of priors on acupuncture. I found the invited commentary that accompanied this paper was really interesting and talked a lot about how we talk about placebo effects in very general terms a lot, but things like cultural expectations can feed into placebo effects a lot, which might be a factor here. So, look, I'd be convinced if we have a lot of robust data that shows that acupuncture works, great. To quote Tim Minchin, what you call alternative medicine that's shown to work.
Yeah.
Medicine.
Yeah, exactly. And this was a randomized trial, and we don't, they particularly like looking at things like acupuncture. I think it's nice to be able to have that.
Yep. And, and again, I think this is one piece for, 300 some odd patients. There are subjective scores in here and some other stuff.
Right.
And who knows, but it's, I could be convinced
at
some point, maybe. So last up today, we have the association between adolescent blunt use and uptake of cigars. So this is an interesting study. So they looked at adolescents in 4 public high schools outside of Philadelphia. They had about 1,825 of them, and looked at blunt use. So basically the use of blunts are taking a cigar, taking all the tobacco filling out of it, and using the tobacco wrapping leaves and filling with marijuana to basically make marijuana cigars. Of those, first of all, 14% of the adolescents had smoked a blunt or had used a blunt in the study period. And of those, there was an odds ratio of 23 of progressing to ever cigar use at 2 years. Interestingly, probably the most fun fact in this is that 40% of all cigar use in adolescents is for blunts and not for smoking cigars per se, which I guess is something. We talked about this, I think it was last week or the week before, about how it's so hard to disentangle marijuana habits from tobacco habits
Yeah.
because there's so much overlap in smoking, and this is a good
Yeah.
example of that.
Yeah.
But I mean, not surprisingly, people who smoke.
Yep. Right.
But also tobacco is addictive and is using cigar tobacco leaves as a vehicle for marijuana, a way that kids get exposed to nicotine addiction that they may not have necessarily. Again, this is observational, so it's not causal, but it's certainly interesting.
Yeah, these studies are so hard. I think, again, because not only, they're observational, but also people are self-reporting their use and their lifetime use and trying to remember when you use or how much, that can be challenging. But I think there is some sense of intuitiveness that it kind of makes sense, that there may be this sort of, association.
Yep. And again, yeah, I think even if this is all just descriptive and not causal, it's certainly interesting and important stuff to know. And I don't know, there's all sorts of potential arguments, but if marijuana is legal without tobacco, does that mean kids will smoke marijuana with tobacco less, or will that lead to more tobacco use? Or, I mean, there certainly seems to be a lot of data, and we've talked about a lot of it here, on how kids who vape are more likely to smoke cigarettes. So I don't know. It's really interesting, especially as the combination of vaping and legalization of marijuana is just totally changing the landscape over the last 10 years.
Yeah, absolutely, and hopefully someone is working on that right now as we speak.
There's plenty. So really interesting stuff. So thank you for joining us today. Join us next week for a year in review. It should be Tuesday at 3 p.m. as usual. Of course, send us your questions, comments, follow us on the usual social media channels, Twitter, Facebook, LinkedIn, Pinterest, all that stuff. Get these papers and more for free open access at JAMANetworkOpen.com.
Thanks, everyone. Bye.
Take care.